I'm Dr. Sandaj Rudris. I'm an associate professor of neurology at Northwestern University and in Chicago. I'm the director of the ALS Lewis and Solia Clinic, part of the Les Turner ALS Center in Chicago as well. We're going to talk today about emerging strategy in the diagnosis and treatment of amyotrophic lateral sclerosis, or ALS. This talk today is supported by an independent educational grant from Mitsubishi Tanabe Pharma America. These are our objectives for today that we hope to touch upon. So we're going to go over the analysis of the underlying pathophysiology of ALS and the barrier to accurate and early diagnosis. We'll utilize interdisciplinary strategy to manage the systemic burden for patients with ALS. We will discuss the efficacy and safety of disease targeting and supportive therapies for patients with ALS. And we will identify challenges and opportunity in using shared decision-making and supporting patient adherence. These are my disclosures. So we can't really start a talk about ALS without paying our due respect to the father of modern neurology, or Jean-Martin Charcot. His genius lies in the fact that he culminated about 50 years of slow neurological development and coined the term amyotrophic lateral sclerosis. He correlated the clinical presentation to the pathological presentation and called ALS amyotrophic lateral sclerosis based on the presence of amyotrophy clinically and the sclerosis of the lateral corticospinal tract on pathology. But perhaps you guys have heard about ALS through the Ice Bucket Challenge. This event happened back in the summer of 2014 or 15, where many very famous people started dumping ice cold water on their heads, and really were able to raise funds for research for ALS. You can see here our team at Northwestern who also did the same thing. It was very popular. And unfortunately, this disease also affects the rich and the famous. So for example, in the US, it's known as Lou Gehrig disease based on the New York Yankee baseball player Lou Gehrig, who had the disease in his mid-30s and unfortunately died with it within 3 years. But maybe the person that is the most famous is Stephen Hawking. Everybody knows about him, and he actually lived with the disease for a very, very long time, about 50 years, which is really unheard of, especially that he was told he's going to die within 2 years. If you haven't watched this movie, I really encourage you to do so. It chronicles his life with the diagnosis of this disease and how he lived with ALS. It's a very good movie. Let's talk about the epidemiology of the disease. When we think about ALS, we think it's really a rare disease, but it's actually not that rare. It has the incidence of multiple sclerosis, but because the patient unfortunately died with this disease within 3 to 5 years of diagnosis or onset, the prevalence is low. There are 30,000 patients living with this disease in the US at any point. It's a male predominant disease. Males get the disease at 1.5 more often than females. And it affects patients in their mid-50s. However, if there is a family history or there is familial ALS, patient will have this disease earlier, up to 10 years or even more than that earlier. So they will have it in their 40 or mid-30s. When we talk about ALS, amyotrophic lateral sclerosis, what we mean pathologically is really the degeneration of the upper motor neuron and the lower motor neuron. The upper motor neuron is the cortical neuron. the cortical neuron does communicate with the lower motor neuron that is in the brainstem nuclei, the cranial nerve nuclei, or in the anterior horn of the spinal cord. So the simultaneous degeneration of the upper and the lower motor neuron that will lead to the clinical muscle weakness and atrophy that we know of when we talk about ALS. As you can see, in some instances, you can have just the degeneration of the upper motor neuron, and we call that primary lateral sclerosis, or you can have only the degeneration of the lower motor neuron, and we call that progressive muscular atrophy. But when we speak of ALS, when we say ALS, we mean degeneration of both the upper and the lower motor neuron. You will hear me talk about upper and lower motor neuron down in the talk, especially when we present the clinical manifestation of the disease. I just want you to understand what I mean when I talk about that. So again, the upper motor neuron is the cortical neuron, the lower motor neuron is the brainstem nuclei, the anterior horn cell nucleus neuron that connects to the muscle. And this actually gives this disease significant heterogeneity. And this is one reason it is very hard to diagnose and hard to actually find therapy for this disease, because it's extremely phenotypically heterogeneous. As I told you earlier, we have ALS when we have degeneration of the upper and the lower motor neuron, but sometimes we can have only the upper motor neuron and we speak about primary lateral sclerosis, or only the lower motor neuron and its progressive muscular atrophy. If the disease is only bulbar, if only the brainstem nuclei are the one degenerating, so if it's lower motor neuron predominant, we talk about progressive bulbar palsy. If it's upper motor neuron predominant, we talk about pseudobulbar palsy. Cognition is usually normal, but when we test patients, they have impaired cognition, and it can go all the way to the frontotemporal dementia. Some patients have only atrophy of their arm, and the disease looks like it's stuck there, doesn't move. So this is what we call flail arm syndrome, flail leg syndrome. These are slower progressing form of ALS. As I said earlier, it happens in the mid fifth decade usually, but we can have patients who have disease way in their 20 or even younger than that. We talk about young onset ALS when it starts before the age of 40, and we talk about old onset ALS when it starts in the 8th decade, for example. Some patients, unfortunately, have a disease that progresses very fast, and some have a very, very slowly progressive disease. Most patients have a disease progression of about 5 years, but within these patients, we have patients who die with the disease, especially with certain hereditary form within the first 2 years, and some patients will have disease for decades. And depending on when the first symptoms appear, we can have bulbar-onset disease when patients present with speech and swallowing issue, or we can have spinal onset disease when the weakness affects the arms or the legs. You could see here, it's very hard for somebody who doesn't take care of ALS patient to really wrap our mind around all these phenotypic heterogeneities. Let me give you an example of a real patient that I saw in my clinic a few years back. So this is a little bit younger patient. She's a female, she's 48 years old, who presented for trouble walking in November of 16. So when you ask her about her symptoms, she says that back in the winter of 2015, she noticed loss of balance, some falls, and was told she was limping. She's a runner. She didn't think anything of it. She thought maybe she's running too much, and she continued to run. By the summer of that year, she is now falling more often. She's even tripping on her right foot, and she noticed that when walking, she's now dragging it. By the winter of 2016, she has now more weakness in her right leg, and she has cramps and twitching. And by the summer of 2016, she noticed that the twitching are now diffuse, affecting the other leg, the arms as well. And she has stiffness in both legs, and her walking is really difficult, and she can no longer run. So we can see here really how protracted this onset is. It took more than a year for this patient to come to the clinic, and the symptoms were very insidious. For the other patient, the onset of the disease was spinal. However, this patient, she's 58 years old, I'm sorry, and she has slurred speech and difficulty swallowing. That started, and she came to see me in September of 2019. So also about a little bit more than a year before her symptoms, she noticed that she was slurring her words. And that slurring was a little bit worse in the evening when she's stressed or she had a little bit of wine. After that, she noticed that this slurring was happening at random time during the day, and it didn't matter if she had some wine. She became more concerned. And about 6 months later, she went and saw her PCP, who did the right thing, or had CT that was normal, and referred this patient to see a neurologist. By March of 19, she was seen by a neurologist who ordered an MRI and a swallow study. Her MRI was normal, and her swallow study noticed some aspiration. She was referred to see a speech therapist, but she wasn't given a diagnosis. So you can see here it's a little bit protracted course again, starting in the bulbar area, and about this patient hasn't even given a diagnosis or hasn't seen an ALS specialist yet. A 58-year-old patient noticed that when traveling, he was not able to put his bag in the overhead compartment. A 63-year-old had 1 year history of left hand weakness. He had difficulty with button, turning key in the ignition, and clipping his fingernails. This patient had difficulty with fine motor control. And as you notice, none of these patients complained of any pain. These symptoms are painless, and none of them had any sensory symptoms. They didn't have any numbness, tingling, no paresthesia or dysesthesia. This is important. So after getting that kind of history, a protracted course of weakness with no pain and no sensory symptoms, we examine the patient. We really want to make sure we take away all their clothes and examine them in their underwear, because we want to see the distribution of the atrophy. We want to see the presence of fasciculation. And our exam usually pays attention to the presence of the upper and lower motor neuron involvement. So when we talk about lower motor neuron involvement, that's the weakness, that's the muscle atrophy like we see over here and over here. The presence of twitching that we can see, fasciculation. And of course, sometimes the patient may describe cramps. Upper motor neuron also give you weakness, but it's more like a difficulty with coordinating movement than true weakness. They have increased tone or spasticity, they have clonus, and when we check the reflexes, they're hyperreflexic. Patients who start with the disease in the bulbar area, usually with speech and swallowing issue, we can definitely see the involvement of the lower and the upper motor neuron in the bulbar area. So of course, the lower motor, these patients will have trouble with their speech, they have dysarthria, they may complain of difficulty swallowing, dysphagia. Because they cannot swallow, they will be drooling, so they have excess saliva. And when we look in the back of their throat, they have palatal droop, they have the tongue weakness, they have significant atrophy, it has this, what we call a scalloped appearance. And if we pay attention to the tongue, we can see the fasciculation. Upper motor neuron involvement is usually when the speech is trained and very slow. They can have dysphagia as well. They have pseudobulbar affect. And what that is these episodes of crying and laughing spells that, crying and laughing spell that is not provoked by itself. Sorry about that.
Thank you for calling Northwestern.
They can have a hyperactive gag, a snout, and a glabellar reflex. So they have, when we check the reflex, we check the jaw jerk, and the jaw jerk is usually brisk. So how do we make the diagnosis of ALS? ALS is a clinical diagnosis that is supported by characteristic electrophysiological feature on the EMG or the electrodiagnostic testing. Unfortunately, to this date, there is no clinical laboratory test that will confirm the disease. The labs that we order, their role is actually to rule out any condition that mimic ALS. When we enroll patient in research, we have a set of criteria called the LS Corial criteria that help put patient in categories. We talk about suspected ALS, we talk about possible ALS, probable ALS, and definite ALS, but these are not diagnostic categories. That these are used mainly for research. But also the most important thing is most patients don't have sensory involvement. They don't have autonomic dysfunction. There is no visual impairment. Cognition is usually normal unless it is tested with a neuropsych testing. And when it's tested, up to 50% of the patient can have some cognitive dysfunction. And there is also no movement disorder. So to make the diagnosis, we really rely on our clinical exam. We have to have a very, very detail-oriented clinical exam, take a good history, examine the patient, and get all these information that we need, mainly the presence of upper and lower motor neuron dysfunction in one anatomical segment. So what is our approach for the differential diagnosis? When we think about differential diagnosis of ALS, we focus about the finding, the signs that we have. So if, for example, patient presents with fasciculation that are present with no weakness, we talk about benign fasciculation. We really focus on ruling out diseases that we can treat. One of them is multifocal motor neuropathy with conduction block, which is mainly a lower motor neuron disease. Let me put this away. A mainly lower motor neuron disease. So if the main symptom is lower motor neuron dysfunction, we rely on a good nerve conduction study and an EMG looking for conduction blocks. This is a disease that sometimes has positive anti-GM1 antibody, and we can treat it with IVIG. In this case, patients usually don't have atrophy, especially early on. They have significant weakness, and it affects the finger extensor. It's usually happen not in a segmental fashion like you expect for ALS, but in a nerve distribution. A brachial plexopathy or neuralgic amyotrophy. This is a disease that presents with severe pain that is then followed by significant atrophy and weakness. However, as I said, in ALS, there is no pain, and the history of pain is very important. Kennedy's syndrome or spinobulbar muscular atrophy, this is a disease, this is a hereditary disease. And in this case, patient can have lower motor neuron involvement of the bulbar area, they have weakness, but the progression of the disease is very, very slow. They have gynecomastia and they have prominent chin fasciculation or chin myokymia that sometimes give away the diagnosis. A pure motor form of CIDP could be in the differential. However, the weakness in CIDP is always symmetric or most commonly symmetric. And this is also where we rely on the nerve conduction and EMG that will show sensory findings and also will show conduction blocks. Sometimes we use a muscle biopsy to rule out inclusion body myositis. However, this is also a disease with a very typical presentation. It affects the finger flexor and the quadriceps, and it has some elevated CK. This is when the biopsy will give away the diagnosis. If the disease is upper motor neurons predominant, in this case, we want to rule out hereditary spastic paraparesis, and this is also hereditary disease that is very, very slowly progressive. genetic testing will help. Patients usually have no weakness. The EMG will be completely normal and may sometimes show a little bit of a neuropathy. We talked about primary progressive, we haven't talked about this, I'm sorry. We talked about progressive lateral sclerosis that is a form of ALS, but there's also primary progressive multiple sclerosis. In this case, it's important to get the MRI of the whole spine and add a CSF analysis looking for oligoclonal bands. The most important thing to rule out is really getting a cervical spine MRI and making sure there is no cervical spondylosis that is causing these symptoms. And this is treatable. As I said, as we're approaching the differential diagnosis, we're really focusing on treatable mimicker that we can change. However, sometimes clinically, we can see that there is manifestation that are more suggestive of ALS. Now, if the fasciculation are diffuse, for example, they're more likely to signify ALS. Most people with benign fasciculation, it's very difficult to see the fasciculation clinically, but also they tend to be localized, they're not diffuse. If we see bilateral wasting of the tongue, both sides, if you have a 12 nerve palsy, you will have weakness and atrophy of the tongue on just one side. But unfortunately, when you have bilateral wasting, that's more indicative of ALS. If you add to this weakness of the tongue, if you add a brisk jaw jerk, you basically make the diagnosis. There is this thing called split hand, and this is a specific atrophy that happened in the hand. It affects the thenar eminence way more than the hypothenar eminence. Remember, if we have an ulnar nerve palsy, we expect to see atrophy of the FDI to the same extent as the atrophy of the ADM muscle. These both muscles are ulnar innervated muscle. However, patients do have atrophy of the APB and the FDI more than they have any atrophy of the ADM. And this is because of the pincer grasp. We think that the cortical representation of the APB and the FDA muscle are close together, and because the pincer grasp is so important, and they atrophy together, and you get this very specific split hand syndrome that almost pathognomonic of this disease. If patient present with a head drop, of course, you can see this in inflammatory myopathy or myasthenia, and of course, you want to rule out cervical spondylosis, but a dropped head and cervical weakness can suggest ALS. And then the presence of excessive laughing and crying spells, this we could see on top of the presence of the wasting of the bulbar muscle, can signify the presence of upper motor neuron in that area and is more suggestive of ALS. And finally, the presence of the frontotemporal dementia phenotype with any other weakness is very suggestive of ALS as well. So as you can see, to summarize the clinical approach, we take a very thorough history, we do a detail-oriented exam, and then we approach the differential diagnosis based on the symptom of the patients. I don't have this here, but the most important thing we do is the EMG. The EMG, or electromyography, it has two parts, the nerve conduction study followed by the actual needle study. On the nerve conduction study, we want to make sure that the sensory responses are normal, which is important, and we want to make sure for the motor responses there is no blocks that will suggest multifocal motor neuropathy or motor CIDP. The EMG, when we do the needle study, we are looking for a diffuse involvement in multiple levels. And we look for the presence of active denervation and reinnervation put together, present in multiple distribution in the arm, leg, and bulbar muscle, thoracic muscles. This is very, very important in helping make the diagnosis of ALS. Does imaging help us with the diagnosis of ALS? Most commonly, the MRI of the brain is normal. Sometimes we can see an upper motor neuron predominant increase signal in the corticospinal tract. This is actually rare, could be seen sometimes in normal patient when it's symmetrical, but we can see here it's definitely asymmetric. However, imaging is used to really look at, for research, we can measure the cortical thickness of the of the um, of the cortex, which is important for patients who have frontotemporal dementia or have cognitive impairment. And we can also measure and look at the using certain technique like diffusion tensor imaging, really look at the corticospinal tract. And you can see here, we can measure the thickness of these corticospinal tracts. Imaging of the spinal cord is important to rule out any cervical spondylosis. You know, the cord is very thin. It has the thickness of your pinky muscle, and it lies in a part of the body that is susceptible to motion, right? It's next to the heart, next to the lungs with the breathing. And the MRI is very sensitive to any kind of motion. So it's very important to gate and to take the MRI in a way that will resolve that. So the research that is based on studying the spinal cord has multiple hurdles. And just recently, we were able to kind of try to subtract the motion that happens because of the heart and the lungs. And you can see we're trying to measure the thickness and the perimeter of the the lateral corticospinal tracts and the anterior horn cell. As you can see it here, anterior horn cell is here, lateral corticospinal tracts are here. So these are emerging imaging technique to help with the diagnosis and the longitudinal follow-up of ALS. We so far talked about sporadic ALS, but how about familial ALS? About 10% of patients have a positive family history. And as I said earlier, the age of onset can be up to 10 years earlier than the sporadic form. And unfortunately, not surprisingly, there is a significant heterogeneity. The very first gene to be discovered, SOD1, back in 1993, was followed by so many other genes. Unfortunately, many of these genes are responsible of ALS, rare form of familial ALS. This has remained this way until 2011, when C9orf72 was discovered. This is an important gene because it causes up to 5% of the sporadic ALS, and it explains up to 40% of the familial ALS. It also helps tie in frontotemporal dementia to ALS with patients who have C9orf72 mutation could have frontotemporal dementia, could have ALS, or could have frontotemporal dementia and ALS. Genetic discovery in ALS are very important because they actually taught us what we know about the pathophysiology of this disease. For example, we know that they help us understand the different dysfunction, if it is in the RNA binding protein, if it is cytoskeletal dysfunction, if it is mitochondria. All these genes helped us understand that. They also helped us really model the disease in cells, in kind of the worm, the fly, the fish, and even the mouse model of multiple familial ALS. The most important one is the SOD1 ALS. And really, thanks to the study of the familial ALS, we understand what we know now about the pathophysiology of ALS. But how about the sporadic ALS? Because remember, all we know is specific to the familial ALS. But we know now that sporadic ALS happened probably because of a modifier gene and an environmental factor. We know that intermediate length repeat in the ataxin-2 gene, for example, increase the risk of ALS and may actually cause a little bit different kind of ALS. As far as the environmental factor goes, we know that the male gender and smoking, for example, are the most important, but there are many other things. They're still actually being studied, and there is no clear connection between any of these and ALS. And this is really to summarize it. We know now that the sporadic ALS happened probably because of dysfunction in all these pathways. And on top of that, the genetic makeup of the patient and whatever they're exposed to environmentally. We know that very excessive physical activity may also be a risk factor. So how do we determine the prognosis when we talk to patients and they ask us, okay, how will my disease evolve? What do I have to expect? There is this very nice article that was published a few years back that used a computer model to come up with a prognosis. And what panned out to be the most important is really the age of onset of these patients. The younger you are, the better the prognosis. The diagnostic delay, as I told you, most patients take about 1 year, 12 months to see us. And this has been replicated everywhere in all the multidisciplinary clinic. So if we see the patient earlier than 12 years, that means that, earlier than 12 months, that means that their disease is going to be fast progressing. If we see them longer than that, it's probably more on the slow side. What is their progression rate per month? We do have ways to measure progression. It's called the ALS functional rating score. Usually patients do kind of drop about, on average, a point per month. So measuring how many points patients lose by month can give us an idea about their progression rate. Therefore, vital capacity, when we see patient in clinic, we measure their breathing, and the forced vital capacity is a good indicator about how progressive their disease is. The lower the forced vital capacity at the first visit is an indicative of a worse prognosis. Patients with bulbar-onset tend to progress faster. If they have a definite ALS diagnosis at the first visit, also these patients tend to progress faster. The presence of frontotemporal dementia and the presence of C9 or F72 repeat expansion. So all those things, we use them as we see patients to kind of have an idea about their progression. So we're going to change gear now and move to the treatment and the management of patients with ALS. As you noticed, I do work in a multidisciplinary ALS clinic. I don't see patients by myself. I see them with multidisciplinary staff, and that includes a pulmonologist, an occupational therapist, a dietitian, a speech pathologist, a social worker. We need all these patients to really address all the symptoms that our patient can have. This multidisciplinary care has been endorsed by the American Academy of Neurology. It has been proven to actually improve the quality of life of patients and improve their survival. We do now have a treatment for any symptom that the patient may have. All symptoms are treatable, and we can go over them one by one. Cramps are common in ALS. They tend to be early when weakness is very mild. And remember, I told you that usually patients have no pain, but cramps can be painful. They will say, yes, we have pain, but when we have a cramp, outside of the cramps, they will have no pain. So there is one actually clinical trial that showed the effect of mexiletine in treating cramps in ALS patients and showed that 150 twice a day is effective in treating cramps. However, all the other drugs are used by experts. Gabapentin is my go-to drug because it's easy to titrate, is really helps promote sleep on these patients, help with certain kind of other bodily pain that they may have because of positioning, and it's effective against cramp. But there is no evidence-based for this. This is just an expert decision to use these drugs. Some patients may have spasticity with the cramps. We use baclofen as a muscle relaxant to help with the cramps and the spasticity. We can use any other type of muscle relaxant as well. And usually you have to understand that cramps appear early in the disease, and unfortunately, when weakness happens, they tend to disappear. They don't last a long time. Because of significant upper motor neuron dysfunction, we can have spasticity or stiffness. Spasticity is sometimes very difficult to treat in ALS patient. So we start with baclofen, we titrate it slowly. We can use tizanidine, we can use benzodiazepine. But if patient has primary lateral sclerosis or upper motor neuron predominant ALS, and they look like they're going to be slowly progressing, we have used intrathecal baclofen pump. The advantage of the pump, it allows you to increase the dose of baclofen without having any of the systemic side effects. Drooling or thialuria is maybe the most embarrassing presentation of ALS. It's the one thing that really has a very, very negative impact on quality of life. And the patient don't make more saliva. It's just because they cannot swallow, they don't swallow their saliva. And we've used multiple things. We use amitriptyline, nortriptyline because they have an anticholinergic side effect, and we take advantage of that anticholinergic side effect. We've used glycopyrrolates, scopolamine patch, atropine drops. We can, even if it's really bad, and especially if the patient has already a PEG tube, we can use Botox in the salivary gland. We have also radiated the salivary gland, but this is really extreme when patients have already a feeding tube and not using, not being fed by mouth at all. Pseudobulbar affect, this episode of crying spell and laughing spell, they can be embarrassing. Usually when they're laughing, the patient are okay with it. When they're crying, they may be disruptive, and patient would like to have them taken care of. So before, we used to use all type of SSRI. We usually used amitriptyline, that was very effective. But recently, in the past few years, we've been using dextromethorphan and quinidine more and more. And the reason we do that is very small study showed that, and the patient actually anecdotally, they will report that as well. Then when they use the combination dextromethorphan and quinidine in Nuedexta, they notice that their speech is a little bit better, their swallowing does improve a little bit. We used to use the amitriptyline before because it will help the saliva and help the pseudobulbar affect at the same time. Now that we're using more and more the dextromethorphan and quinidine combination, we have to use something else for the saliva. The risk of using dextromethorphan and quinidine is a prolonged QT syndrome, and we usually get an EKG before starting the medication. Respiratory management in ALS is very, very important. And we measure the forced vital capacity in our patient when they come to clinic, all of them. Prior to the pandemic, we used to do it in all the patients. Now with the pandemic, and since measuring forced vital capacity is an aerosol generating procedure, we relied more and more on the overnight oximetry. So this is a device that the patient put around their finger, sleep with it, and it gives us an idea of their oxygen concentration during their sleep. We also, during the pandemic, used home sleep studies a little bit more often. Together with measuring the forced vital capacity, we measure the maximum inspiratory force. And really, this is important to monitor. Remember, the diaphragm is a muscle, and one way to monitor diaphragmatic function is to measure the forced vital capacity, the overnight oximetry, and the maximum inspiratory force. The reason we do that also is to determine when is the best time to start patient on non-invasive ventilation. And it's important because non-invasive ventilation has been proven to improve quality of life and really slow disease progression. As we can see here, it's BiPAP. We use a BiPAP machine, and that's why we work very closely with our pulmonologist and to start our patients as early as possible. The guidance from the AAN is to use the BiPAP when patient breathing FVC is below 50%, but we do know that overnight oximetry or respiratory issues during sleep start way before that 50% mark, and patients with FVC as high as 80 and 75% could have nocturnal hypoventilation and can have hypoxemia when they're sleeping. So that's why we play an important, detecting the respiratory dysfunction is very important, and we measure it with all the ways, all the tools that we have. Of course, sleeping with something on your face is not easy. Patient need time to adjust. There are multiple masks that the patient can use, and it does take some trial and error. Unfortunately, there is no clear recommendation, but it's patient specific. And that's why we really work very closely with our respiratory therapists to determine what's the best face mask that the patient can use. The other important thing is really airway clearance. And mobilization of secretion. If we cannot mobilize secretion, they will accumulate and there will be a breeding ground for infection. Death from pneumonia and respiratory failure is the one reason patients die because of ALS. They die because of failure of their diaphragmatic muscle, but also because they are not able to clear their secretion and they end up having pneumonia. So we use this device. It gives some small oscillation to the chest wall and moves the secretion. It's called the vest. We use an insufflator, exsufflator that help mobilize the secretion, help patient with weak cough. And this is how it's used. And really one very easy thing is to work with an ambu bag and increase the compliance of the chest wall. We call it physical therapy for the chest wall. We give the patient these ambu bag and teach them how to use it. And it's important to increase the chest wall compliance because the patient are sitting, they're not taking deep breath. There is atelectasis that form. And again, these atelectasis will be a breeding ground for infection with which we want to avoid. Nutrition is very important. We know that weight loss is a negative prognostic factor. A drop in weight by 10%, that make the disease progress faster. So we try to avoid that as much as we can. We can place feeding tube either percutaneously or through interventional radiology. And they really help the patient keep their weight steady and get them the nutrition. Either the patient is unable to swallow or it's difficult for them to swallow because bulbar ALS, or the patient is really losing a lot of weight despite the amount of nutrition he can have. So in the clinic, we monitor their weight very, very closely. And if we can see that it's dropping, we introduce the idea of a feeding tube very early. Patients always ask about what should I eat? What kind of diet is best? Well, unfortunately, the only answer I have is try not to lose weight. We work with dietitians who can help them figure out what the best diet and how to kind of complement it and make sure they're not losing weight. But unfortunately, there were a small study that looked at different type of diet with high protein, high fat, but these were short duration and small study that it's difficult to have any conclusion that come out of that. So we just monitor their weight. We'll help them maintain a healthy weight and maintain their weight and avoid weight loss as much as possible. We also thrive at making sure that the patients stay independent as long as possible. And they do that with adapted devices. You can see here either larger adaptation so they can grasp the key, or they can grasp the silverware, or cut the food, or button their shirt, for example. There are multiple ways to help the patient remain as independent as possible. And that's why we work with our occupational therapist in clinic who will introduce this idea and walk them through it. Mobility aids are important. We use an ankle foot orthosis early on to help with the foot drop. We recommend patient use a walker or a wheelchair to avoid falls, and really to preserve energy. That is important. We introduced the idea of a wheelchair early because we don't want them to get tired getting from point A and point B and not enjoying what they need to do there. And communication is very important, and preserving communication is one of the important things we work on. And there are multiple speech generating devices now. This one uses the eye gaze. so the patient does not have to wear any specific glasses or any devices, just looking at the screen and selecting the letter so they can speak. The device can actually bank patient voice, so we can generate speech in the patient voice and not have that typical robotic voice that we think of when Stephen Hawking used to use. So let me move on after talking to you about the symptomatic treatment and all the things we do in multidisciplinary clinic, what all the therapists use to make sure that we address every symptom that the patient might have. Let's talk about disease-modifying therapies. And so far, we have riluzole, which has been around for a very long time. Edaravone was approved in 2017, and dextromethorphan and quinidine Nutexa, who can help with, who was actually approved as a symptomatic treatment, but as I told you, it may have some neuroprotective effects. This is the initial trial that was done with riluzole. And when we do clinical trial in ALS, we look at the curves for the patient on active, on the investigational product, and look at the curve for the patient who are on the placebo. And we want to see a separation of this curve. We want to see that there is a difference between the patient on drug and placebo. And we can see it here in the study. It seemed like 100 milligram a day was the best dose. Patient usually take riluzole at 50 milligram twice a day. It's about probably 2/3 of the patient will have used riluzole at one point in their disease. It's very well tolerated. It sometimes causes some increased fatigue that will go away if the patient goes through a small drug holiday and it's followed by taking the drug once a day and then twice a day. Certain patients may have increased liver function enzyme, and that's why when we start the patient on riluzole, we monitor liver function monthly for the first 3 months, and then every 3 months for the first year. It's very rare that we have a bump in LFTs, but sometimes if it happens, a drug holiday will take care of it as well. It's very, very rare to have patients who will not be able to tolerate riluzole. Edaravone is, as I said earlier, has been recently approved in 2017. Edaravone is given IV. Riluzole is a PO, is a tablet. It's a pill that's taken twice a day. Edaravone is an infusion. It's infused over an hour. It's given in cycles. So the first cycle is a 14 days of infusion, and then it's followed by a drug holiday for 2 weeks, and then the patient gets the drug 10 days out of the 14 every cycle, and it continues like that. So this is the initial trial. After a 12-week observation period, we can see a nice separation again between the patient on placebo and the patient on the Edaravone group. And it seemed like the patient who benefited the most are the patient with a faster progression of their disease, who had a definite diagnosis at presentation. About probably a quarter of the patient will be on Edaravone at some point of their disease. An oral version of this drug is being developed and will probably increase the use of this drug. It's a little bit difficult, of course, to use an IV drug versus a PO drug. So why is it that we only have two drugs, two disease-modifying drugs? And really, if you look at the research in ALS, we had many clinical trials, and there were about 50 clinical trials. 23 of them, half of them were just in the past decade, and they all failed. And you may have an idea now, what, after all I told you, what are the challenges of developing drugs in ALS? And the first thing I told you is how phenotypically heterogeneous this disease is. And we have ideas, thanks to the study of the familial ALS, of the different pathway involved in the pathogenesis of this disease, but we're still really in the dark when it comes to sporadic ALS. We don't know what causes this disease. You saw earlier that it takes at least a year for a patient to present to an ALS multidisciplinary clinic after their first symptom. So this is an important time. A year delay of diagnosis is neurons that are dead that we can no longer recover. Clinical trial design, and I'll explain to you how we're trying to change the design, hopefully to accelerate drug development and drug discovery in this disease. We've learned a lot, and we've over these years how to design clinical trial in ALS. And also the other thing, we don't have a biomarker that will help us do clinical trial that are shorter and use less patient. And finally, I think there is still one more. We don't know if we are reaching our target, if we are actually getting the drug to the motor neuron, whether it's the upper motor neuron or the lower motor neuron. And finally, the preclinical study are really limited to the familial type of ALS. The SOD1 mouse is a very good model of the SOD1 familial ALS, may not tell us exactly what the sporadic ALS shows. Talking about clinical trial design, let's tell you a little bit about how we came up with trying to change the way we do clinical trial in ALS by adapting the platform trial for ALS. And really, this was triggered by the fact that in the past 5 years or so, there is significant interest in the ALS space. Many drug companies are interested in doing research in ALS. So this kind of created a little bit of pressure here and pushed us to think creatively about how to change our design. And traditionally, when we do a clinical trial, we have to build an infrastructure and tear that infrastructure down when we study another drug. So every drug needed its own infrastructure. And when you think of it, like you have the Olympic, you're building a stadium for every game. It's not very sustainable. You cannot do it that way. So how about we just build one infrastructure and have it there and just add drugs as they come in, have what we call a master protocol, and then add different new protocol every time you want to study a different drug. And this approach has been actually successful in cancer. That's why there was a push from the FDA to think creatively about ALS clinical trial and adopt new methodology, and the platform was one of them. It has been proven that using a platform kind of design, you will decrease the number of patients and you will do the study in less time. So that means it's going to cost less and help find an answer quicker. Again, this is the stadium we were talking about. You have the master protocol, which is the big house, and then you have the different, this is a building, the different apartments are the regimen-specific appendix. You run the study the same way. You have the main inclusion and exclusion criteria being very similar, and you run the study for 24 weeks, and you have after that an open label part of the study that the patient really like to be able to get the drug. The problem with ALS is really to be on a placebo when you know this is a deadly disease, but unfortunately we do need the placebo arm. However, doing a short placebo controlled arm followed by open label will increase participation in this study. And let's tell you a little bit what's in the pipeline, what's coming out. So recently, there was a report about this drug. It's a combination of two drugs, phenylbutyrate, sodium phenylbutyrate, and TOTCA. They were combined, and a study was published last year showing a difference between ALS patient and placebo. And when they did the open label extension of this study, they also noticed that patients who were on the active drug did much better and lived about 6 months longer than the patient who were started on the active drug later after the placebo portion. So this is undergoing FDA review right now. It's also open for a phase 3 trial that is fully that stopped enrolling, and hopefully by the summer we will know if this drug is going to be approved or no for ALS. Other things in the pipeline is the use of stem cells. My patient always asks me, what about stem cells? What about stem cells? So to grow to grow a motor neuron and have it connect to the muscle is going to take forever. One way to really use the stem cell technology is to, in this case, specifically in this clinical study, they used an autologous mesenchymal stem cell that were modified to produce neurotrophic factor. And after a period of observation and harvesting, they were injected multiple times in the intrathecal space. And this study showed that doing that multiple injection intrathecally is very safe, has very little side effects. However, unfortunately, this study did not reach its main endpoint. Let me go back. Oh. So unfortunately, this study did not reach its main endpoint. It did show a trend toward improvement in patients who were started early with an ALS FRS that was less than 35. And also there was a trend in the biomarker. They looked at certain biomarker, and these biomarkers showed that they were going in the right direction. So stay tuned. This will be also we'll find out in the next weeks or months what if there will be another trial, or if they're also submitted to FDA, what the FDA will allow them to do. One of the area that is really evolving right now is the treatment of familial ALS. And this is very exciting. It's, as you can see, if you have one mutation, with the development of gene-targeted therapy now, it's easy to correct these defects. So there is a study that targets SOD1, and there is a study that targets C9orf72. Unfortunately, yesterday, they announced that they stopped the development of this trial. It does not mean that, I think we just have to wait and learn a little bit more about this disease. It's more the pathophysiology of the disease in SOD1 is a little bit clear. We know there is a toxic gain of function. So if we decrease the load of SOD1, we may improve the disease. However, in C9orf72, it's a little bit more complicated than that. And the first approach has not been effective. So how do these ASO work, or antisense oligonucleotide? As I said earlier, you have an abnormal DNA, it makes an RNA with a mistake, and this makes a faulty protein. This is the toxic gain of function. Now, if we take a synthetic piece of DNA, we have it match the defect in the RNA, it will destroy that RNA, and there will be it will decrease the making of this abnormal protein. So this was used in the VALOR study. This is an ASO that is targeting the abnormal SOD1, and it has a 6-month arm followed by an open label extension. In their study, that focused on the very fast progressing patient. You could see there is a little bit of a difference there. Unfortunately, it's not statistically significant. However, this study is still ongoing, because if you look here you look at the patient with SOD mutation that are progressing at a slower pace, you could see that the difference is statistically significant here. So we have to wait a little bit and see the result of the open label extension arm of the study. And really, gene therapy is now very exciting, as so the drug is injected intrathecally. It does go to where it's supposed to. It targets the lumbar spine, and hopefully does the effect it's supposed to do. Other way to use gene therapy, we talked about the oligonucleotide, but the other way is to use a virus to introduce a gene silencing, or you could use the virus to deliver a gene. So we are at the dawn of gene therapy, which is very exciting. And I think the genetic form of ALS will be the first one to benefit from this targeted approach. Okay, I think this brings me to the end of my talk. Thank you very much for listening. I am happy to answer any questions. Thanks.